can see from our previous speakers how fortunate I am to work with Dr. Levine and Secretary Tennis, and how difficult it is to follow them in speaking, plus a skit and stand between you and dinner. So I will do my absolute best. And I will also start with sort of an apology. This is my fourth talk of the day, and I'm also recovering from a bad cold, and you might be hearing I was the one coughing in the back of the room. So if my voice fades away or I break into coughing, I apologize, but then you'll know what's going on. So let's see here. Perfect. So I want to give you a brief overview and update of the prescription drug monitoring program and where we are at. And when I say PDMP, it's synonymous with ABC MAP. We like lots of acronyms in state government. ABC MAP is Achieving Better Care by Monitoring All Prescriptions. That is the official name of Act 191 that was passed in 2014 that creates and establishes the PDMP. So this evening, I'm going to talk briefly about its background and purpose, the old versus the new PDMP system, definitions and requirements, and then I'm happy to take any questions that you have. So in terms of background, many of you likely know this, but a PDMP is, what our PDMP will be is a statewide electronic database monitoring tool that will gather information about prescribing and dispensing of controlled substances. Pennsylvania has had a PDMP. It's been operated through the Office of the Attorney General, and it's only been tracking Schedule II controlled substances. The new PDMP that will be operated through the Department of Health will track Schedules 2 through 5. The purpose of the PDMP is threefold. Number one, to improve the quality of patient care by providing prescribers and dispensers access to information about all controlled substances dispensed to a patient. Purpose number two, to encourage prescribers to refer addicted patients to a treatment center for evaluation. And number three, to aid regulatory and law enforcement agencies in the detection and prevention of fraud, drug abuse, and criminal diversion of controlled medications. And as a practicing family physician who has, during residency, practiced in Washington State during the time when we rolled out our PDMP, I am excited for the opportunity for us to soon have data that will help us make more evidence-based decisions from a practicing point of view. It's also important to know with the PDMP that patients will have the ability to access their records by requesting them through the Prescription Drug Monitoring Program Office in the Department of Health. And thirdly, this is something that we are working on the details with the Office of the Attorney General, but any concerns regarding law enforcement issues, regarding diversion, et cetera, will be made through the Office of the Attorney General. So Pennsylvania is the 49th state to pass a health-related PDMP. And I'll have to say there are some advantages from being second to last. We've beat Missouri. No offense. I'm from Iowa originally, so it's it's a neighbor. But the other benefit, as Secretary Murphy often says, is that hey, we have the ample opportunity to learn about best practices from about everywhere else, and helping us create and establish our PDMP. And it really is true. For example, right now we are in the midst of developing a number of policies related to the operations of the PDMP. When you're building something from the ground up, we have to decide, well, who can access the PDMP? Can it only be the physician, or can it be delegates? And are those delegates licensed or unlicensed? Is it okay to have medical students accessing the PDMP on behalf of a prescribing physician? And so we have to ask and answer those types of questions and develop those policies. And so it's fortunate that all of the states around Pennsylvania have PDMPs, have these types of policies in place, and so we can get their policies and make sure that we are somewhat regionally on par with our neighboring states. Act 191 gives access to this information after you register with the system to a variety of groups of individuals. And they include the following: prescribers, dispensers, key staff from the Office of the Attorney General, the Department of Health and the Department of Drug and Alcohol Programs, designated personnel from licensing boards within the Commonwealth, medical examiners and coroners, patients, and PDMP officials from other states after such time as there are appropriate MOUs for interstate data sharing that are put into place. And speaking of interstate data sharing, similar to the challenges that we have with electronic health records, where interoperability is a significant challenge, we're dealing with the same thing on the PDMP front. We have states that have created their own systems, like New York, and we in Pennsylvania are working with a vendor called Apris and their specific product called AwareRx that will be a standalone web-based PDMP tool, but it will also has the capability of being integrated into certain EHRs. Epic is one, that it is fully integratable, if that's a word, right now, and other systems are in development, being tested, etc. So there are many different types of systems, and the challenge with EHRs, they don't communicate across states. But just this past Friday, I signed a memorandum of understanding with the National Association of Boards of Pharmacy for Pennsylvania to enter into use of something called the PMP Interconnect, which allows us to share data with our neighboring states and to access data about patients from those states through our PDMP. We all know that this problem does not, opioid prescriptions do not respect state borders, and so we have to be able to access and share data back and forth across state lines. A brief comparison between the old and the new, if you will. So the current system, again, has been run through the Office of the Attorney General. It collects only Schedule II information. Pharmacies were previously required to submit their dispensations on a monthly basis, and through that system, health professionals were not able to access that system for any sort of health-related purpose. The new system, again, is transferring from the Office of the Attorney General to the Department of Health, specifically the Prescription Drug Monitoring Program Office. It will collect expanded schedules of controlled substances. Pharmacists and dispensing pharmacies will be required to submit the information about prescriptions to the database within 72 hours. And most certainly, which is a big point of the database, is that prescribers and medical professionals will have access to the database to be able to have some data that can support the clinical intuition of the disease of addiction and help get patients into treatment that they need and that they deserve. So requirements for dispensers, again, pharmacists and pharmacies. These are the groups of individuals that are submitting data to the AwareRx system. And again, within 72 hours, they will be required to submit all the information that you see here about each prescription that is filled for a controlled substance. Responsibility for prescribers. So for the physicians and others with prescribing authority that are in the room, we must query the system for each patient the first time a patient is prescribed a controlled substance by the prescriber. We also, if a prescriber believes that the patient may be abusing or diverting, and we must indicate the information obtained from the PDMP system in the patient's record if the patient is a new patient or if it is determined that the drug that's being requested should not be prescribed based on information obtained from the PDMP system. So just a brief snapshot of the team structure for the office for those who might be interested. The PDMP office is one of 5 areas that I oversee as Deputy Secretary for Health Innovation within the Department of Health. We are incredibly fortunate to have Meghna Patel as the founding director for this office. Meghna comes to us from Geisinger, where she is responsible for ICD-10 rollout. She did so with a happy group of physicians, under budget, and early before the deadline. So we have someone that is on board that knows how to manage large, complex IT projects. So we are incredibly fortunate to have her on board. We have a statistician that's already on board, as well as a chief technology officer with extensive experience in health communications and tailored education for health professionals. And we are recruiting an epidemiologist and an administrator to help keep everything on the tracks and moving forward. It's also important just to touch base about definitions so that we're all on the same page. Controlled substance definition, not going to read it, looks probably very familiar to many of you on the room, but this is what we're talking about. Dispenser is someone who's authorized to deliver a controlled substance to a patient by a lawful order of a prescriber. You will see that there are several exceptions to who is classified as a dispenser at this point in time, including correctional facilities, wholesale distributors, hospice providers, and veterinarians, among others. And a prescriber is a person licensed, registered, or otherwise authorized to distribute, dispense, or administer a controlled substance within the Commonwealth. And in terms of administration and oversight for the program, we have our board of directors, the individuals that you see listed here. We also have an advisory group that will soon meet and start reviewing drafts of various policies that we are developing to get their feedback with regard to with regard to operational policies related to the PDMP. And there are a few questions that Marty, I don't know if Marty is still in the room, but PAMED Society, you're fortunate to have Marty Ranowski now working for you. He was a colleague of Rachel's and mine until he came to join you. But Marty thought these would be questions that would be of interest to you. And so I'll just run through these briefly and then happy to take any other questions that you may have. First question is, how is the PDMP supposed to work in my practice? Again, from a clinical standpoint, it is to aid in the detection of the disease of addiction and help make more informed referrals to treatment. However, in terms of the operations and how it fits into the clinical workflow, I often hear three questions that come up about this. Number one, what do I do in that moment if I look in the PDMP and I see data that supports red flags for addiction? Number two, how do I address some of the challenges that finite information may cause to the logistics of my clinical workflow for that clinic session that you're in? And number three, how do I know how to access treatment options? I can tell you that we're working on some technological solutions to help with that third question that we're exploring within the Department of Health. But the first two questions, how to handle the red flag and how to handle that the disruption to your clinical workflow, are going to be questions that, as individual providers and as clinic systems, that will be questions that you'll have to figure out how to address. With the second question, in terms of disruption to your clinical workflow, you've got a 10-minute time slot. A patient comes in with severe chest pain concerning for an evolving MI. We have procedures in place to handle these types of emergencies. And so I'd encourage all of us to think about how we might handle the length of time sometimes that these conversations require in terms of making sure that we address that warm handoff that Gary talked about earlier. How will the state be using the PDMP? In a lot of ways, but two top ways that we'll be using the data from the PDMP is that we'll be keeping an eye on data trends in terms of overuse of these prescriptions by patients and perhaps some aberrant over-prescribing practices from prescribers. And what we do with that information in collaboration with groups like PAMED Society and so forth, we're in the midst of developing those policies, but we'll be looking at overall data trends. We will also be exploring as a state ways to submit unsolicited reports about patients that may have the concerning disease of addiction to physicians that may not yet be registered with the system to see that information yourself, but we want to make sure that we get this valuable information to you, and so we're exploring that as well. Number three, what are the expectations of individual physicians? Well, the first and foremost is that I would expect that as physicians that we would employ the benefits of this data tool to help improve the care of patients that need our attention and need our help in order to get through some tough clinical situations. And number two, I'd also expect that as we roll this out and as we think ahead to enhancements to this program, enhancements to how we can make this work into the clinical workflow, that we welcome your ideas and your input and how to improve that. Right now, we are focused entirely on getting the IT tool up and running, making it successful within the constraints of Act 191 as it is now. But we've also started jotting down a fairly extensive list of what we call legislative enhancements to make the PDMP an even more effective tool moving forward. And so when I get to that point, welcome very much your input into making those changes happen. Number 4, what do I do if a red flag pops up with regard to a patient? This is where a lot of the discomfort comes into caring for patients that have the disease of addiction. And it calls upon all of us to practice that conversation that you have with these patients and their family members about the concern that you have for the disease of addiction. It's important to build that trust, to exercise sound judgment when you see the clinical signs, you're getting the data from the PDMP, and then thirdly, to refer these patients to treatment to the best of your ability. And number 5, how well would the PDMP be integrated into my EHR? I regret I did not bring that list with me this evening, but again, APRIS, the vendor that we are working with, we are the 25th state that APRIS is helping with building a PDMP tool. Again, there will be the online version. There are so many EHR options out there. Some of those much smaller EHR companies, APRIS is not, this tool will not integrate with those. It's ready to integrate with Epic. They're targeting the big systems with big market shares. There are many other EHR systems where they are in pre-development, development, or testing phase so that the AwareRx product will be available embedded into the EHR.